Waveform capnography. We've really come a long ways with waveform capnography. Really, it's being used for almost everything. If I could ever get Adam to order the pieces to make it so that we restock it for you guys. But it can determine if a patient's having an asthma attack, they're about ready to stop breathing. It can help identify trauma issues, shock in patients, metabolic acidosis or alkalosis. It does a lot of different things. And so by taking a look and using it appropriately, it can give us a good insight into which direction we really need to go on with our patients. We know that if we hyperventilate a patient, we're going to see the end tidal drop, and this patient would end up having respiratory alkalosis. If we hypoventilate, or if a patient is breathing slow, the end tidal is going to be high, and we have elevated respiratory acidosis. I actually saw a couple times this summer. It was pretty interesting. We had a patient in cardiac arrest, and they went from, it was pretty low, it was in the teens, all the way up to 71. And I couldn't feel a pulse, really could not feel a pulse. And it was like, well, we need to keep doing CPR. And I'm like, but the end tidal's up to 71. We stopped doing CPR and transported the patient, and the patient actually did have a pulse, but it was just so weak that we couldn't feel it. And the patient ended up surviving as we went through with the whole process and the whole treatment of them. But yeah, it's a great way to make the determination of ROS, even if you can't feel that pulse. Here's a normal waveform. This ultimately, as the patient takes their final breath out, that's what we're really looking at measuring. Should be between 35 and 45. The way this waveform actually looks will give us some indication. If it comes up and we have a delayed upstroke, usually people will say shark fin. These are pretty strong shark fins, but usually asthma, COPD, or bronchospasms for our patient. It's harder to get air out. Return to spontaneous circulation, yeah, you're real low here, and then all of a sudden you see a big spike. We can also see it if someone is in diabetic ketoacidosis. They may have a very low end tidal. If they're metabolically acidotic, generally we will see low end tidals. If they're metabolically alkalotic, we will see higher levels of end tidal CO2. Tells you how good you're doing for CPR. Can help make a determination if your patient has stopped breathing. You know, we go ahead and we see this, and all of a sudden nothing. It's immediate. Unlike with a pulse oximetry, it can take up to 90 seconds for that to go ahead and change. So, anybody have any questions on your FlowSafe CPAPs? We have quite the discussion going on with the CPAPs. Do you guys automatically turn them up to 15 liters so they're getting a PEEP of 10? I've been arguing this for the last month. This is the reason why I bring it up, because the Whisper Flow had different PEEPs, and the only ones we bought were the PEEP of 10s. So you automatically had to put someone on a PEEP of 10. But with this new device that we've been using and approved, we can titrate the PEEP. And you know, everybody's like, oh, we don't want the medics going ahead and titrating. Well, first of all, a PEEP of 10 is more dangerous than a PEEP of 5. And a lot of people can't tolerate the PEEP of 10. I said to everybody in the meeting, I says, I teach the medics, start low, work your way up. You're more likely to go ahead and have them accept the CPAP if you start low and work your way up versus just hitting them with 10 right off the bat where they can't tolerate it. So as far as what we're concerned with in our system here, you're okay to titrate. Some people are sticking with the fact that the Whisper Flow said 10, so you have to go to a PEEP of 10, but we're not going to be that way. We're going to let you guys think a little bit. So, when do we use it? Well, heart failure patients, number one, get the first nitro on board before you put the CPAP on, then put the CPAP on, give your nitro every 5 minutes. Don't forget about that. The nitro will cause some dilation in the coronary arteries and in the arteries in the lungs. allow blood flow to flow a little bit better. Plus, the CPAP will help push any fluid out of the lungs. CPAP for asthma, COPD, make sure you have your nebulizer set up. Remember, their problem is getting air in, not getting air out. Or getting air out, not getting air in. And you don't want to cause bronchial trauma with these patients. So you have to have the medication to help force it deep down into the lungs so you can start bronchodilating. We also use it for freshwater drowning because that will also help push some of the fluid that may be in the alveoli out. Just make sure you're watching blood pressure is pretty good. Remember, CPAP, vague valve mask, that can also go ahead and decrease the preload, which can ultimately decrease the cardiac output. Yep. PEEP helps keep the alveoli open during exhalation. But again, that PEEP at 10, it can be very difficult. And of course, the PEEP at 10 does decrease the preload rather quickly, or can rather quickly. Yeah, this is a good example of how CPAP feels to the patient, you know, going 100 miles an hour down the road and trying to exhale against the wind. We don't have the CPAP that you hook the nebulizer up to it already or has it in there. You guys can hook it up, and basically your nebulizer is going to go right in between, kind of right where that is. Pull this piece out and you can put it goes right in there. Anybody have any questions on the CPAP? All right.